we'll filter in. We'll talk a little bit. Welcome. This is Health 2.0 New York City. And we have a really amazing panel tonight. And we're really glad you all came on out. So this is also being live streamed. Mike, are we live on YouTube right now?
Yes, we are.
Excellent. So the hashtag for the event is on your handouts. If you guys didn't get a handout, say something, we can send one to you. On this also is the Wi-Fi password, as well as the Twitter hashtag, which is H2NYC, which helps us spread the word about the live stream and everything else. Some really amazing people, not just up on the panel, but also in the room. You guys are a community that has helped so many companies get going, including companies that you guys are running. So when I see guys like Jack Barrett from Legal Health here, Howard Steinberg from D-Life, Atul Kumar, various different startups, and of course these amazing people. It's very inspiring because I remember when a lot of us were just at these events thinking of ideas and discussing them, and then amazingly starting them and then growing them. So I don't know where you are personally in the life cycle, but there's all sorts of people here who could help, not just as members of the team, but as mentors, maybe investors. So the networking time is a great part of this, but also we've got some great content too. So if we do have great content today, it's thanks to Kim Overs. So Kim is an attorney from Pfizer. She can introduce herself a little bit better. But she also curated this panel to bring all these amazing folks in here. So as you know, we're already behind schedule, but we're going to play around with things a little bit. So Kim, you want to come up and introduce your panel a little bit? And we'll also switch over to the Matt for our first presenter. We're actually doing a couple of different things here today that are technologically more difficult than we usually do. So we're having some fun with that.
Thanks. So thank you, Alex. And hello, everyone. Thanks for coming. Thanks to Cohen Resnick for hosting us. We really, really appreciate this great space and the opportunity to be here. So yes, we have a great event planned for you tonight. We have a wonderful panel of speakers. And I think one of the exciting things about tonight is that we're going to get to see how augmented, virtual, and mixed reality are impacting the healthcare space from all different vantage points. So we're going to see this from the R&D perspective, medical education, clinical applications both for the doctor and for the patient, and marketing and advertising. So I think there's a lot to see. Plus, one thing that you don't ordinarily get to do at one of our meetups is get to try out the technology. So we're going to have demos at the break, and I hope you all enjoy them. So, and one other thing, this is a panel on augmented and virtual reality, so I think it makes sense that one of our panelists is virtual. And so I'm going to start by introducing him. Kevin Halleck is the senior manager of Pfizer's Innovation Laboratory, and he is currently the modeling and visualization lead who manages Pfizer's Visualization Center. Now I'm going to turn to each of the panelists to introduce themselves briefly. Mike, do you want to start?
Sure. Hi, I'm Mike Moret. I'm the founder of Confidio Labs. We are a specialized agency dedicated to immersive multimedia. We've produced a range of VR and AR, as well as now mixed media programs on behalf of the life sciences industry. We've been doing it for 4 years.
Hi, I'm Osama Chowdhury. I work at NYU as a neurosurgery resident, and I'm a founder and CEO of MediViz, which is a company seeking to advance medical visualization through holographic mixed reality.
I'm Andrew McAlevey. I'm a clinical psychologist and instructor on the faculty at Weill Cornell Medical School. I work with virtual reality in a few domains, in psychotherapy for PTSD and in pain management in the burn center.
Hi, I'm Tammy Rich, and I am a mom on Boston Children's Hospital's Family Advisory Council. But I'm actually here tonight as sort of the hype girl, spokesperson for my friend Melanie Perron, who runs La Fête Papillon, a social agency designed to help patients with stress and caregivers with stress and anxiety and pain. And I'll be demoing her virtual reality bliss.
We can't hear back here.
Yeah,
So you need to speak louder.
You need to use mic.
that on? Can you hear me?
No.
Is it great? Now can you hear me?
Yes.
Sorry. My name is Tammy Rich, and I am a medical mom on Boston Children's Hospital's Family Advisory Council. But I'm actually here tonight representing sort of the spokesperson for my friend Mélanie Perron, who runs a social agency called Le Fête Papillon in France. And she has a VR product called Bliss, which I'll be demoing for you. And Bliss is designed to help patients and caregivers to manage stress, anxiety, and even pain during procedures.
Hi, I'm Denise Kirk. I am a neuropsychologist by training. I'm a research scientist at Kessler Foundation and assistant professor at Rutgers, New Jersey Medical School. And I use virtual reality in application as evaluation tools and treatment in cognitive rehab to try and find different ways of evaluating patient populations and finding treatments that are better for those patient populations. I work primarily with traumatic brain injury.
Thank you. And so now we're going to start things off by setting the stage a little bit. Dr. Chowdhury is going to explain to us a bit about the different types of technology in this area. And then Mike Merritt in his presentation is going to cover basically the history and the key stakeholders in this space.
Thank you, Kim. Can everyone hear me? Yeah, great. All right. Welcome, everyone. Thank you for joining us this evening. Augmented reality, virtual reality, mixed reality, this is definitely one of the most exciting domains to touch healthcare. And I'm sure, as you'll see from our panel of speakers and from what I hope to present to you folks today as well, that the potential for this sort of technology in truly transforming how physicians, how patients, how every sort of healthcare provider interacts in the medical community and with each other is truly transformative. And I just want to take about 5 minutes and go over just a brief introduction of what is AR, what is VR. These terms are thrown around, in the industry left and right, and often we don't have a clear understanding of it. And that's fine, because honestly, the terms themselves are going to continue to evolve as the technology continues to evolve over the coming years. And so from here, I'm just going to go over to the next slide here. So this is Webster's dictionary's definition of AR and VR. And it's quite long, but VR, there's a focus on creating an artificial environment through which the senses can be overtaken essentially by virtual media. And AR, on the other hand, the focus is on not replacing your physical reality surrounding you, but enhancing it in one way or the other. The last term that's actually a little more complicated, and I'll get to it a little bit later, is mixed reality, which in many ways some folks think it's a merger of AR and VR, and others think it encompasses the entire spectrum. Simply put, the way I consider AR and the way I consider VR is all about immersion. The whole goal is to take you away from your sense of reality, your physical space, and bring you to a whole different experience. And AR is all about enhancement. And this kind of all started, kind of halfway through the 20th century. This is a video, actually. This is called a sensorama. This is 1962, and this is probably the first real VR device. And in addition to light, sound, it also claimed to affect your sense of smell, which I don't think many companies can handle right now. So it was pretty groundbreaking for that time. I don't know how often it was used. We go to the next slide. This is a video as well. This gentleman, Ivan Sutherland, he's the first person to have considered creating a head-mounted display which can show virtual information. And he called it the Sword of Damocles. And it was very simple what he created. It was literally a wireframe box. But again, this was thought to be groundbreaking. It gave you stereoscopic, true three-dimensional visualization of an object through a head-mounted display. And if you go to the next slide, this is the video as well. Over the years, as the technology continued to evolve, it was really used more in professional use cases. This is the work that NASA had done. There was some enterprise use cases as well considered at the time for manufacturing. It really hadn't taken off for gaming per se. And here, this is some initial experiments within healthcare using virtual reality as well. The graphics are obviously not as impressive as what we have nowadays, but you know, this early pioneering work was essential towards getting to where we are now. We go to the next slide. This is a video as well. Just all videos for you guys. This here is just kind of going over how entertainment contributed to our sense of AR and VR. And so everyone knows Star Trek and their concept of the holodeck, which would be considered VR. And then some of the later movies now are all beginning to adopt this sense of VR and AR as well. And so this is my favorite superhero, I guess, Iron Man, and demonstrating really an AR interface here. And so, you know, our understanding was shaped by what we saw in the movies and by Hollywood as well. This, I don't know how many of you folks consider it AR, but it's really the first practical and widespread demonstration of AR. And that's the yard line right there. And that itself was groundbreaking when it first came out. Obviously, now you can have cameras flying all around the field and it's overlaid. But back then, that one line there was something never seen before. And this here is what I was talking about when we're talking about shifting of the definition. So this is the first paper to describe the word mixed reality, and really it encompasses this field from pure virtual reality, where your entire physical environment is taken over, to augmented reality, where kind of some digital information may be overlaid to help one. And if we go to the next slide, over the years, really in the 2000s, what started taking off were these devices coming in. So this is Google Glass, an AR device, which at the time was used to kind of just overlay information in the corner of your screen. And this is one of the VR devices that folks in the operating room started to experiment with as well. Those are Snapchat spectacles. So really in the 2000s, you see this transition of these hardware companies coming out with incredible heads-up displays. And here, this is the first mention of Oculus. So Oculus as a company started, this is a picture, but they started as a Kickstarter campaign. And they raised, it must have been a goal, like a record amount of $2.5 million just to fund this project. And eventually, obviously, Facebook bought them, and now they're this $2 to $3 billion company. But they all started out of a vision that a gentleman had about just creating a more immersive display for gaming. And so, if we go to the next slide, what you'll see is that really over the years now, it's gaming that has taken the lead in terms of the evolution of this technology. This is now where we are at nowadays. This is Microsoft's HoloLens. It's a device I'll speak about later as well. But we're not getting into this domain where there are these several large companies that are now working on what people consider to be the next revolution in computing. And that is this whole field of AR, VR, and mixed reality. And so in the upper right, you can see, like, the last revolution was considered to be the smartphone, and now you have these companies like Magic Leap, Meta, Microsoft, HTC, and Oculus really defining what will be the next kind of way that humans interact with computers. And so, you know, there's still much left to be done here, obviously, and it's probably one of the most exciting domains for not just for healthcare, obviously, but for consumer level engagement as well. It's only going to continue to get better. So that was my brief introduction. I'll hand it over to Mike for the next segment.
Great. Thanks. Cool. Okay, thanks. So, hi everyone. I'm Mike Moret, founder of Confidio Labs, and I was asked to present sort of a perspective from the marketer as it relates to adoption of this categorically, really for the means of optimizing things like storytelling, which is the aim from our view for most marketers across all industries. To get started, a bit about our company, we started in late 2013, early 2014, which is when really it started to get exciting from a tech perspective, as you had just heard. We created a platform that we call Dr. Virtualis, and it's really been oriented expressly around supporting the greater life sciences industries. We've worked with big health systems, we've worked with the NIH, we've built training programs for doctors, and we've also deployed both therapeutic applications for patients as well as educational programs for medical professionals. Just to give you some context, these are some examples of some of the early adopters on the pharma manufacturing side. These are all customers of ours with whom we've deployed a range of programs. So a little bit similar to what you heard, what you're seeing on the screen is our view of how VR is being defined. I like using the phrase immersive multimedia. So we favor immersive multimedia over VR because we don't want really the category to get bucketed to just virtual reality. It's really so much more, as you had just heard. So as a marketer, really what we love and simply what we can achieve with this categorically is the ability to take what's otherwise flat and needs to be produced for screens with borders, take away those borders for the purpose of truly optimizing storytelling, measurably deepening education, and then ultimately elevating engagement. So there's a ton of really compelling quotes across the space. We chose to share just a couple. The one at the top comes from an analyst at Goldman, and this is in late 2015, just demonstrating categorically, again, as you had heard, what this revolution really represents. In many ways, the next big computing revolution. And then a quote from just today, something we came across when discussing the appetite and opportunity for VR. And for us, when we as an organization started to advocate for VR to pharmaceutical marketers, we were met with a lot of reservation. Many of our customers with whom we worked for many, many years suggested that it would never be adopted in our space. And now just 3 years later, finally that boulder that we were pushing uphill has started to come down. And what we're seeing is that people are, while they might not yet have a goggle in their home today, there's this notion that eventually the goggle in some capacity or the ability to receive 360 video will be like the toaster. You may not use it every day, but it'll be in your household. And that's exciting. And as you heard again, it is documented that the adoption of VR is happening at a rate and a pace that's greater than the cell phone. So my interpretation of something you just heard, and I won't really repeat it, but we know it started with the Sensorama in the late 50s. This is another iteration of an early stage head-mounted display, and what's cool about this, it's not too dissimilar to what we'll show you some demos on later. There was a mini sort of revolution, if you will, in the 90s. Those that remember Lawnmower Man, or even those that are fans of Nintendo, might remember that after the Game Boy, they did make an attempt at Virtual Boy. It failed. There is now this notion that it will be coming back, which is kind of cool. But again, the reason really for this was the hardware was too bulky, the price point was too high, and the graphics quality was not sufficient enough. And then it really got exciting in 2012 with this Kickstarter campaign, and this really represented tremendous opportunity. So now just to get you grounded again on our view on why this is exciting, and we tell this story to our clients because most of them really don't appreciate how the largest tech companies in the world have pivoted around this categorically. So when Facebook bought Oculus, that was the single largest acquisition of theirs. It was a $2 billion acquisition. And that was really when everybody started to pay close attention and make strategic pivots. On the heels of that deal, Samsung, as you know, teamed up with Oculus and Facebook. They've created the Gear VR, which has been incredibly successful. Google, shortly thereafter, moved one of their global heads of search, as the largest search company, they moved that individual to the head of VR, even before they had a department. Then, of course, they created the Cardboard. They've since released Daydream and a ton of amazing content to go with those devices. HTC has the Vive. Microsoft has the HoloLens. For those that watch YouTube, you might or might not know that probably about 3 to 4 months ago, YouTube now enables 360 content. So you can hit the 360 button, take that content, drop it in a goggle, or use your phone, if you're viewing it that way, sort of as a magic window into the 360 world, so long as it's been produced that way. But all the video players are getting oriented in this capacity. It's not just YouTube, it's Vimeo, and of course Facebook, of course, has a 360. And then PlayStation, if you are a gamer, it's not just PlayStation anymore, it is PlayStation VR. Take yourself inside of that game. Some data and some insights you might not know, and this is just a summation from 2016. So there were nearly 2 billion total sales of hardware in VR, of which nearly just over 6 million total headsets were shipped around the world. Here's a representation. As mentioned, Gear is really leading the pack. It's a really elegant, fabulous solution. We use it a ton. Sony PlayStation, they only launched in October, and they sold 750,000 devices in a short amount of time just before the end of the year to kind of fall in second place. You've got the Vive and the Oculus behind. Also, interestingly, and this is a good indicator for our customers on the marketing side, global search across the internet grew 4 times for VR just in the past year. And then here is a forecast for you. So 30 million units predicted to be in market by 2020. And for our industry, which is healthcare, it's going to represent a $5 billion market opportunity. So again, from our view, as a company that supports life sciences in crafting this content and building it across channels and across audiences, here is just a snapshot of programs that we've built across these areas. And these are really where we see the opportunity. So patient therapy and treatment, you're going to hear some fabulous presentations around real tremendous therapeutic applications that are in the space. Medical training, continuing medical education, sales training, think of the field reps in the space. Clinical trials, you might not know, but per the NIH, there were nearly 90 clinical trials that utilized VR in 2016. And then lastly, the area that I'm going to focus on for today is around virtual marketing, virtual visits, for which, now with the advent of portable VR, we're deploying these programs across a range of channels, which is really exciting. Okay, so just my opinion, my perspective on why VR is so compelling for a marketer. Firstly, the notion of putting your customer inside of a goggle is quite compelling. And frankly, that screen within the goggle can achieve something that no other screen in the world can claim, which is 100% express focus on the content that you're delivering. So think about that, again, as a content creator or as a marketer. This is sort of feels like the holy grail. You've got their attention because you're depriving them from all other distractions, which, again, no other screen can claim that. It's very natural nowadays to multitask and do many things while watching a show or even at work. When you're in the goggle, you can be sure that your customer is viewing your content expressly. That's powerful. Second, when we orient our storyboards for VR, we take advantage of the fact that humans are conditioned to learn through episodes. We can really exacerbate that quality through the goggle. And then lastly, VR has been dubbed the empathy engine or the empathy machine. So again, in our space, when looking to educate about a disease state, inspire some type of activity, either on the system side or better educate a physician on what a patient might be going through, for the first time ever, we can put that practitioner, as an example, in the shoes of the patient. And it's quite compelling. This all translates, again, to engagement, immersion, and retention. So according to doctors, this is a physician named Irving Lowe, and you can see his first quote, again, giving credibility to the category and why it would be relevant from his view. He actually joined us on a presentation not too long ago, and he shared that as a physician, he learns visually. And he just feels that this is such a natural tool for him to really better be educated and engage in the content that he needs. And then he was just published in an article where he further corroborated that from a marketing perspective, he does believe that this needs to be in the toolkit for big pharma. We'll go through some data, and there's 3 years of data here. So back in 2015 already, for me, one of the most important data points, which is retention of core content, you can see that back in 2015, from a study produced by Fierce Healthcare, content delivered in a goggle was generating an 80% retention rate versus content delivered flat through traditional media, which was in the neighborhood of 20%. Further to that, in 2016, DRG was already reporting that nearly 20% of doctors had used VR in some capacity in their practice. And then lastly, bringing it back to retention, for this year to date, data published is showing that the retention rate has driven up even higher. So we're at the 90% rate, which is significant. When we think about VR as a company, when we're scoping out opportunities and projects, the first thing that we consider is the technology platform. So just to offer you perspective and kind of give you a really simple summation, on the left you've got connected solutions. They're connected because they're literally connected by a cord to your computer. You've got the Oculus Rift and the HTC Vive. Both have different merits and values based on what would be optimal for the content that's being created. And while they deliver high fidelity and they're fabulous solutions, very elegant, they're a little bit rate limiting because they require a setup. Things for us got super exciting with the advent of portable VR, which is where your smartphone is powering the content. On the top is the cardboard, on the bottom is the gear. this opens up all the channel applications. Then when you think about content options, firstly, these are examples of reimagined medical media, if you will, content that pharma needs to produce, and they have been producing for flat screens. We're taking it, we're making it immersive. These are your mechanism of action, your mechanism of disease type programs. And this is really delivering for the doctor that promise of that fantastic voyage through the body. Further to that, we're doing a lot now and seeing a lot of opportunity across live action VR video. There's two styles there. One would be 180 degree, which really represents about 200 degree stereoscopic. This is a program we produced for a big pharma client where the goal was to enable physicians to step into the world of patients suffering from MS. In this case, we produced it as 180 on purpose because the goal was to enable the customer in the goggle to sit across from that patient in their world, and it really mattered that they paid attention to the patient, less what was happening behind them. So that's why 180 plays. If you're doing more site tours and looking to optimize really the full 360, you can achieve that as well. And then lastly, on the marketing side, our perspective of mixed, we call mixed media. And this is an example of a program, we'll run a quick clip in a second, where we filmed a live action VR piece, and then we actually, and technically, we augmented that live action VR by dropping in 3D animations. In this case, it's a character. So I'll show you what that looks like. Let me play on the bottom one.
Biologic. That journey starts in labs like this one. My automated friend here is searching for the right kind of cells and the best way to grow them to produce the medicine we want. Look at him go. Remember, these cells aren't making simple stuff like aspirin. No, they're creating complicated molecules like monoclonal antibodies.
This early development work takes experience and patience. Some might even call it an art.
But it's an art that just happens to use advanced robotic systems to help things along.
So that was a fun project not recently delivered in the space as the first example of mixed media. The remit there strategically with the customer was to enable their audience to take a site tour with the bioreactors, get familiar with the way that they make their specific product, but give it a narrative to make it even more compelling, which is why we augmented it with the 3D animation. And then I'm going to wrap up by sharing just one success story. We were meant to have a colleague of ours from Boehringer Ingelheim here join us. He just had a last-minute cancellation, unfortunately, and his name is Josh John, and he is the Associate Director of Customer Engagement at BI, so I'm going to represent him, pretend to be him. He has single-handedly rolled out, I want to say, anywhere between 10 to 20 VR initiatives across a range of portfolios at this big manufacturer. It's pretty impressive. This is one example which was the industry's first VR detail. And again, this got exciting when portable VR became a thing and we could activate the field reps with really the evolution of what they currently do, which is detail off an iPad and enable that through a goggle, put their target customer in the goggle. So this was their situation. They had a third in market product. They had a lowest share of voice in the channel. The product is Praxbind, which is a reversal agent for Pradaxa. They, as a brand team, were receiving de minimis investment versus the competitors, and they really needed to differentiate their narrative, so they turned to technology. So we created the VR MOA. This program rolled out initially on Gear VR conferences. It was so successful at the conference that we then built it for cardboard. We activated about 500 reps with the cardboard in field. On the success of the cardboard, they upgraded from cardboard to Gear VR, and now it's in the neighborhood of about 1,000 field reps using this, plus additional media we've since released out in the field. And as a result, you can see really just through the merits of this platform and this technology, this particular program, it was a single investment, but it was leveraged at 20 plus conferences. They use it in the US, they use it in Brazil, across Europe, as well as Australia. Latest data is 800 plus field reps are activated now for this franchise using virtual reality as a result of its success. They were the first pharma brand to deploy in field, and this is another important data point here. Their reps are reporting about 4 minutes of quality interactions and meaningful immersion with the content from their target customer. It's important because comparatively, the reps were only getting between 10 to 15 seconds. So you've got a very important story that you need to showcase so the practitioner understands what's happening. You can now achieve that through the goggle, which is bringing tremendous value. Across our industry, it got recognized pretty nicely with some great awards. It was the best sales aid in 2016, recognized by the industry, and then also the best, for Pharma Choice, the best sales aid, most innovative tactic of 2016, and Josh himself got an elite nod from the space for rolling this and many others out. That's it. That's our perspective on the space, some examples of what we've done. My colleague Christina is here, and at the break, we've got about 6 or 7 different demos in the back across Oculus and gear that we'd love to show you guys. Thank you.
Okay, so this is Dr. McAlevey. Oh, sorry. This is Dr. Andrew McAlevey from Weill Cornell, and his presentation is going to be about the clinical application of AR/VR to help patients suffering from various medical conditions and stress.
All right, thank you very much. Great, thank you. As I said before, I'm a psychologist, and so I'm just going to be talking about a couple of clinical applications of VR. VR, which I doubt many of you are aware, has actually been used for a very long time in mental health, although not quite as long as this image might make you believe, but closer than many of you might think. I'm going to talk about 2 applications, each of which has a long time history. VR for exposure therapy, and before I talk about VR, I have to talk a little bit about what exposure therapy is, since probably most of you are not psychologists. Exposure therapy is a type of behavioral treatment for anxiety disorders and several other conditions, and what my work focuses on, especially in exposure therapy, is post-traumatic stress disorder. So I'm working with people who have been through a traumatic experience, something very serious in their lives, and the first-line treatment, the gold standard treatment for this type of condition is something called exposure therapy, in which you work with a patient one-on-one as a therapist, and you have that patient close their eyes and repeatedly recount the traumatic narrative of what actually happened to them. You see them once a week for about 3 or 4 months, every week repeating this same memory over and over again, each time trying to recall all of the details, visual, auditory, sensory details of what actually happened during the traumatic event. This sounds quite difficult, and it is quite difficult for patients. It's emotionally challenging. But in fact, the challenge of it is what makes it effective. And that by repeating it in this way with a therapist there to help you, actually makes it safe enough to approach that memory and process it. Okay? And so starting quite a long time ago now, about 20 years ago now, people started to use VR to adapt this clinical intervention and make it hopefully a little bit better. And there are several reasons for this, some on the clinician side and researcher side, and some on the patient side and clinical impact. So if you're using virtual reality, you first want to be able to use multiple different environments in the virtual world. Obviously, our memories and our imaginations can be as flexible as they want, but we need multiple scenarios. But that also helps you develop an existing library of usable potential trigger scenarios that clinicians can become familiar with and deploy much more easily than having to adapt entirely from new to every patient. You can also integrate scent, as was mentioned before, vibration through vibrating platforms and physical props, I'll give you an example of these later, into the VR experience. And these have been done and been found to be helpful. And what has been developed over the years is an easy clinician interface to actually give new clinicians, people who aren't that experienced with exposure therapy, the ability to immerse their patient into this virtual world that is immediately powerful and does not require tremendous clinical skill and expertise that can be trained using. We believe that this is effective and potentially more effective than traditional exposure therapy because it enhances emotional involvement. If you're actually being exposed to sounds and sights and vibrations that are similar to what was going on when you experienced an event, you're more likely to have the emotional reaction that we think is key in this treatment. This also allows what's considered a graded exposure, meaning that you then become capable as a therapist of ratcheting up the intensity and dialing it back at will, so that you know how intense you're providing a stimulation, and you can protect your patient from being overstimulated, but also stimulate them enough to make it worthwhile. And we know that this actually gives patients a greater perception of control in their therapy, which is very important in this difficult treatment. Okay, so this, as I said, goes back a long way. On the upper left is Virtual Vietnam, which was developed in the 1990s down in Georgia by separate researchers. And it basically was a virtual environment that operated on a single track kind of loop, to my understanding. And the patient had very little control. They had a helicopter environment and a couple of other things. And it was being run off of cathode ray tubes and things like that. After the World Trade Center attacks, my colleagues developed the virtual World Trade Center environment for survivors of that particular terrorism attack. And as you can see, it was a wired headset. It actually included an orienting pole, because the technology back then was quite different to what we have now. And patients were able to use this to recover successfully from PTSD related to that particular attack. What we've been working on with several collaborators in the government, at various institutions, and in private companies as well, is virtual Iraq and virtual Afghanistan for combat trauma. And that's what I'm going to show a little bit more about right now. This has been in development for over 10 years at this point, and has been highly successful. And we're concluding a trial in the next couple of years at Cornell. It's been ongoing for about 7 years now on this. And what you get in virtual Iraq and virtual Afghanistan are realistic enough simulations of actual Iraq and Afghanistan environments. And there's 13 environments at this point, each of which is larger than some towns I've lived in my life. And each of which have a realistic level of detail and varied environments, from city interiors to convoy events through various environments where the therapist can control the time of day, the weather, within reason, can institute explosions and various scripted and totally non-scripted events in the virtual world with the patient present at the time. And the patients get to navigate through the environment on their own with control of their avatar. And they can either choose to do it with a standard video game controller, or some of them prefer, and if the memory is appropriate for it, we have an M4 adapted toy version of an M4 that has controls on it as well. And so the veterans can actually hold this gun as they would have been doing during their experience and navigate through the world using just 2 fingers at a time. And I want to play a video now of a veteran who I didn't treat, and he got much better, but this was done at a different treatment facility. And he just talks about it. This was a produced video from about 5 years ago. Hopefully the audio will work again.
There was a couple of water trucks that were delivering water to this particular village that day. And in the middle of the firefight, they decided they were going to break cover and try to leave the area. We had just had a suicide guy pull out of an alleyway and detonate on us, and we couldn't be sure that that wasn't going to happen again. So immediate course of action was to stop the vehicle at all costs. And it killed a 16-year-old boy and his father. It was particularly difficult to deal with because I had a son that age. It struck home. I went home, and I don't really think I noticed I had a problem. But my wife would tell you I never smiled. We didn't talk as much. A good example is she sent me to the store when I first got back. And we were at Walmart, and she said, "Could you go get some toilet paper?" Sure. I meandered over to the toilet paper aisle. There was like 50 kinds of toilet paper, and I could not make a simple decision. I almost had a nervous breakdown right in Walmart. It for some reason frazzled me because it's just not the life I'm not used to. I mean, it's so simple, but it was such a hard decision to make. I talked to the division psychiatrist. I did not want to hear that. I did not want to hear look, you have the classic symptoms of post-traumatic stress disorder. I was like, you've got to be kidding me, you know? It's the last thing on the planet I wanted to hear. Normally sessions are 30 minutes to an hour. I would put the goggles on, put the headphones on, and I grab the controller and off we go on our patrols. You can't see the doctor, you can hear him. He would ask me, you know, to talk about it. At intermittent intervals, they introduce explosions and gunfire. It's tough. It's tough because you've spent so much time trying to avoid thinking about your deployment, and they're drudging up these memories that you've tried to avoid at all costs. It's difficult. I think it was a great idea for them to put treatment in that format. Better than probably just sitting there and trying to have some doctor pull the events out of you. You know, you're right there, boom, smack, face to face with your worst demons. I mean, am I 100% better? No, I wouldn't say I was 100% better, but I do have my life back. I'm able to do a lot of the things that I did before. You know, I don't have so many issues. I'm not running around angry all the time. And this treatment was, you know, it saved my life probably. It saved my marriage for sure. So I would say if you ask me if it works, yeah, it works.
So you can see from Sergeant Butler's experience that it does seem to be effective, and that at least in the right clinical hands, patients do seem to be able to recover using this technology in a very short amount of time. PTSD is often a chronic condition, and he had a 2-month treatment that was highly successful. I want to jump topics and briefly talk about another exciting use that's been going on for some time now, which is VR for pain management. And many of you are probably slightly more familiar with this. There we go. Okay. Yeah. VR for pain has actually been, it's part of a long-standing tradition of non-pharmacological pain management techniques known as distraction. Many of you have distracted yourselves or are distracted at present, and that's okay. Distraction is highly effective at managing pain. And the reason is that attention is limited. This is also the same reason why magicians have jobs, and as well as pickpockets. Our attention is a limited resource, and pain requires and actually demands attention. If it's not able to get that attention, then it actually ceases to exist or is only able to occupy a lesser part of our attention. And VR so completely immerses one in a virtual environment that it actually reduces experienced pain directly. And this has been known for some time. It's been especially investigated in burn patients, inpatient burn survivors who go through multiple, potentially, procedures for burn wound recovery. Burn pain is intense. It's predictable because it's chronic, but it's also periodic. And it's also temporarily increased beyond a baseline high level with surgical and post-surgical procedures. And so burn has been a major area of focus for some time. Our colleagues at the University of Washington actually developed Snow World to help with burn pain, which has been a well-published, very highly researched virtual environment to manage pain, in which you essentially navigate through a little icy river in a snowy environment, throwing snowballs at happy snowmen who just are so glad to receive these snowballs in the face. And the problem with Snow World, even though it is clearly effective for pain management, is that it had to be implemented in a burn treatment center where water is a very commonly used substance. And so therefore the virtual reality technology had to be fully waterproof and foolproof. And what they actually developed at the University of Washington maybe 7 years ago now were these fiber optic extenders, essentially, for virtual reality goggles that essentially have no electricity going into them, but allow a patient to be totally immersed in a water tank during these procedures and to move their head throughout. So it's a head-mounted display connected to another head-mounted display, essentially. As we move forward, and I'll just jump to say what we are working on at present, is we're working on fully mobile VR technologies, right? So phone-based technology that is fully cordless and fully waterproof, that will be able to completely supplant the intense development and costliness of that installation with something that we could carry around in our pockets. I was also asked to speak for a moment on what I think next directions and challenges are before I cede the floor. We can come back to this later, but basically mobile VR and personal VR equipment is really changing actively the capability of our patients to recover from injuries, psychological and medical. And it's doing so every day, more and more. What we don't know as much about, even though we know quite a lot about exposure-based and distraction-based VRs, we don't know about relaxation and mindfulness-based VR technologies, which are coming into the space at a high rate. And we don't know about how to make these programs more social. These are very effective short-term interventions for patients in need, but we don't know the long-term benefits and the way to make patients use these in their daily lives, and I think that's a major challenge. And so with that, I think I'll pass it off to our next speaker, and thank you all.
Thank you for that perfect segue, which we didn't plan, to speak about pain management and stress and even PTSD. So again, my name is Tammy Rich, and although my background is as a medical mom on the Family Advisory Council at Boston Children's Hospital, and I had the good fortune to step up on a panel and win a hackathon there in 2014, just finding a better way to do discharge. My friend Melanie and I met in 2015 when we were both scholarship winners at, I'm not sure if you're familiar with the acronym HIMSS, healthcare's so crazy with acronyms, but it's the Healthcare Information Management Systems Society. And we were 5 patient advocates that won walking gallery scholarships there out of 45,000 attendees in 2015, and that's what the jackets that Alex and I and others are wearing are from the walking gallery. But Melanie's work was incredibly intriguing to me because she was thinking about ways to develop resources for patients and especially also for caregivers, feeling that it was a very sort of underserved group of people. So she developed this virtual reality product called Bliss. And she wants to not only reduce stress and anxiety, but also to improve quality of life. When she was young, she had a lot of different dreams in her head about what she wanted to do. Apparently in French, cataclysm means beginning, or almost like awakening, where in 2007, her partner, Nicholas, was diagnosed with leukemia. And he had to be in a sterile unit for 18 months in France. And the isolation, the friends that left them behind, the stress was just more than they could bear, and produced something that was not uncommon to me as well, being the mom of a young man born with complex heart defects, a form of PTSD that you just keep replaying over and over the bad times and the worst times, even though you're in the moment needing to be functional during these horrific times. Melanie started to do a little bit of research after she sadly lost Nicholas, and found that in France anyway, there are 12.7 million new cases of cancer each year, or I'm sorry, maybe that's globally. And then in France, it's about 365,000. But another number that pretty much stunned her, and me as well, was that 30% of the French population suffers from chronic pain. We decided to look up some information on our own with this, and we looked at the NIH Pain Consortium, and that the lower line, the bottom line, is taken from that just today. Approximately 100 million people in the United States, which is about a third of our population, suffer with chronic pain. And one interesting thing about pain that you may know is that most clinicians, especially primary care healthcare practitioners, have not received much training at all in pain or pain management for their patients. And another statistic that is also pretty stunning, especially as Melanie has begun to share her product with people and talk with doctors and others about how they feel about helping patients to perhaps need less pain medication, what would that mean for them? We got into a discussion with one doctor where he was saying, well, we kind of like the patients, hate to say it, but drugged and ready to go, so we can walk in the room and do our procedure, gown, glove, and mask, and go on to the next. And we were saying, but we lose a whole day or two of work. We can't eat. We have, all these different things going on. So that doctor actually reached out to us and gave us an amazing statistic. In the United States, the estimated economic impact of pain from direct medical costs to loss of productive time ranges from $560 to $635 billion each year. So we feel like this is something that needs to be addressed. When Melanie created L'Effet Papillon, which means the butterfly effect, but for her it really means the ripple effect, that one action can lead to another and can just change the quality of life for someone, especially in pain or grieving. She really viewed it as kind of a four-pronged approach. She wanted to help folks with leisure and well-being. She wanted to bring culture. Even when Nicholas would hear music, he would just be able to transport himself somewhere else. When he played video games, he was similar to what the doctor was saying, that when people can play this game, it's distracting, which is a good thing going through treatment. And also she wanted to learn more about research, but she was very intrigued by a VR application. So in 2010, she began as a student project with some various folks, and I just wanted to point out in this picture, this is the actual isolation bed that Nicholas had to be in when he got his bone marrow biopsy, his bone marrow transplant. And in France, it's just, there's no color in the room. It's just a very stark and difficult place, and he had to be there for many, many months. And so I'll just kind of jump ahead quickly so that I can get to some of the other points. She has slowly started to do some pilot studies with cancer patients, and she began to treat it more like a clinical study, because as you know, physicians and others really want that evidence-based medicine. They want to show what's the data and prove it, that you can improve outcomes with this care. And so she created Bliss as a dreamlike world to really help people, again, that word, sort of transport them to another place. It has sound, and it has a view that you see. People put their hands up as if they can make a difference, but it's all contained within the world. And I'm going to do 3-minute demos for you where you can move your head around and see even to the sides. But she began to work with some patients in particular and looked at patients with bone marrow punctures, and has a video up on her site, which I'll be able to share with you, that you can watch yourself, where this patient had 5 milligrams, and on her 5th one she got to use Bliss for the procedure. She needed no pain medication. She experienced no pain at all, which was pretty remarkable. And it also has several other uses. This is very interesting, that it turns out that President Macron did a demo with Bliss in 2016, and this photograph in the lower right was just on Slate Europe front page a couple of days ago, and Melanie stayed with me last week, so we were kind of learning these things together, and pretty excited about how the story is almost telling itself when it comes to something like some relief from this pain and stress and anxiety. So her dream is to have it be available for everyone, and here is her contact information, which again I had cards and some resources for her from her work. But this is kind of like what the world looks like inside those inside the Oculus. So thanks so much for your time. I really appreciate it.
Thank you, Tammy. And is Francie Grace in the room tonight? Another walking gallery
Nancy
member?
Grace is here?
She was supposed to be. So
Wow.
just so you can see what Tammy was talking about. So this is the walking gallery, and similar to Melanie. And you should definitely try out the Bliss. It's awesome. I tried. We're members of the Walking Gallery, so show everybody back.
And Boston Heart Mom on Twitter.
Boston Heart Mom, add Boston Heart Mom.
Yep.
So this is for my first company, Fair Care MD. So we inspired Regina to paint things for us, and she painted the backs of our jackets for 2 of 400 or so people that she's done this for. And just tell me for a second, how many of you are physicians or researchers or scientists, you know, highly educated? How many are attorneys, accountants, leaders at hospitals or pharmaceutical companies or large healthcare companies? How many people have a new idea in healthcare, want to fix something? How many of us are patients? At some point, we're all patients, right? And here's the thing. I think Esther Dyson said it worst. I'm sorry, Esther. When she said that I wish more bad things would happen to more great people, so they would come to healthcare and help us fix it. Okay, and that's what you guys are here for, right? That's what inspired us. That's what inspired Melanie. And the whole idea is that we get inspired to fix something because something really bad happens. Because this is important stuff. That's what got most of us here in this room tonight, right? That we wanted to do something meaningful with our abilities and what have you. So thank you for coming. We have a little bit of a break now. I think we've had some inspirational things. We have a couple more inspirational ideas coming up too. And there are demonstrations. Where are you going to do demos?
I'm going to do mine right here.
Okay, demos here for Bliss. I've done it. It's awesome. And then in the back, we have Matt. Mike. Good. Mike's going to be back there. And we'll come back in like 15 minutes. So look, drink, be merry, and talk to each other. So that's a good segue too, because I want to thank the owners of this beautiful venue who have let us use it graciously for the first time. We used to do events back at your old place.
Yep.
Down on 20, was it 12?
12 Avenue of Americas, yeah?
Yes, we did it twice or 2 or 3 times. Those are great events too. But this is even bigger, even better. And I just want to thank Ravi, Raghu Nathan. Come on up here and tell us a little bit about what Cone Resnick is. Did anybody know what Cone Resnick is? You think they're lawyers? Anybody think they're lawyers? Doctors? Indian chiefs? Well, Ravi's going to tell you what they actually are.
Thanks, Alex. I know everybody needs a lawyer when you are starting up the company, so everybody will know the lawyers.
That's right.
I know everybody will know the attorneys because you need them to set up your company and then take care of everything else. Cone Resnick is a tax, accounting and advisory firm. We work with companies throughout their life cycle. Like a lot of the startup, where they need us is in terms of which company you should set up. It should be a C Corp or an S Corp or LLC based upon what is your long-term plan. That's where that's when I think we first enter into consulting with the firms. And then as they are growing up, and then the discussion about where they want to keep their IP in the US or outside the US, depending upon what the market for their product is. And as they are growing, where they need some VC funding and other stuff, so that's where we come in and then also do the auditing, make sure that you have filed all your tax returns, you are maximizing all your R&D tax credit and everything else. Predominantly, I would say it's a one-stop shop where you are going to get your compliance side, but also going to get your advisory side. We also do sort of a mentoring for a lot of the startup companies too. So as people are having any questions on either accounting or tax, feel free to give us a call. I do have a couple of my colleagues here, Sean Scolaro and Jason Zimmerman. Again, send us an email. I'll make sure that Alex gives us our contact information. We'll put it on the meetup. So if you guys are having any questions, feel free to send us an email. We'll be happy to help you out. I don't want to take any more time. I know we got panelists has been giving us a lot of good information how VR and AR is shaping up the healthcare. Alex, thank you.
Thank you, Ravi. Let's get a big round of applause for Cohen Resnick. We're very fortunate to have some great sponsors, PricewaterhouseCoopers, and DataArt, and Amazon, and Epion Health, and the American Medical Association. So it's been a long time, but we've really got a great group of folks behind us. So I'm going to play you one little video, and then we're going to get on to Dr. Karsh. This is from Pfizer. And while we don't generally play other people's videos about them being here, it is pretty awesome. So let's see if we can get this to work.
For scientists, we have to look at a lot of information. And you can think about it as a scientist has an enormous landscape around them, which is filled with information, and they have to identify the critical information that they need in order to move forward. So a way to think about it is if you walk outside and it's very foggy. Virtual reality, what it does is it removes the fog. My name is Kevin Halleck. I'm a physical chemist and biophysicist by training. My role at Pfizer has to do with computational modeling and data visualization. The VizCube was built by VizBox. Most environments like the VizCube are used for architecture or engineering. What the VizCube allows people to do is it allows everyone to look at information, say a protein structure or brain anatomy, and you don't have to be an expert in order to participate in the discussion. By lowering the barrier required to access that information, it allows everybody to get up to speed on the amount of information that they need to know in order to research a drug faster. I think virtual reality will end up impacting every stage of drug development in the pharmaceutical industry. It'll allow researchers to explore their data faster. I mean, they won't have to come to something like the VizCube. In the future, you'll be able to look at it on your phone, you'll be able to look at it on a pair of goggles. It will impact clinical studies because it'll allow clinicians to have an easier time engaging patients who are testing the drugs or testing a procedure. It can impact therapies because you'll be able to identify which parts of somebody's behavior using a virtual environment need to be impacted the most in order to improve the patient's life. We're at the beginning of the journey.
Okay, no applause required since Kevin's not here. Although he might be watching on YouTube. So thank you, Kevin, for sharing that non-confidential version of Pfizer getting a VizCube, which is pretty cool. Without further ado, we're going to move along to our next presentation, which is Dr. Denise Kirsch of the Kessler Foundation. And now you're going to use, okay, so we're going to switch. Introduce yourself.
Hi, I'm Denise Kirk. I'm from the Kessler Foundation, and I do work in rehab. So today, I'm going to be talking about VR as it applies to rehab. And as a neuropsychologist by training, I'm going to be focusing largely on the cognitive application, but I am also involved in a collaborative study with a colleague of mine who's a biomechanist, and we have a study in the balance domain as well. Traditional rehab, whether we're talking about PT or OT or cognitive rehab, is limited in a couple respects, in my opinion. And those areas really are these two. I feel like in one respect, they lack the real-life complexity and dynamic nature to really get at complex daily functions. And with respect to cognition, this prevents us from being able to test an individual and see what their performance looks like in daily life. So for example, if you're evaluating them on a paper and pencil test in a quiet room with no distractions, that's not much like real life. So a lot of times we can miss impairments. We fail to document the difference between patient populations and healthy individuals because of this. With respect to treatments, it really prevents us from being able to get at those complex functions. For example, multitasking, which I'll be talking about a little bit later, requires you to be doing a couple of things at once. We really don't have great ways to get at some of those more complex, higher level functions of the brain. Using VR within rehab allows us to capitalize on the benefits of that technology. And the first thing is that it allows you to create greater ecological validity. And that's a very popular buzz phrase, which basically means doing the things that you do in your daily life. And I don't mean specifically like if you are having difficulty doing the laundry and talking on the phone at the same time, you would create a virtual environment where you're doing the laundry and talking on the phone, but rather you would create a virtual environment that would challenge you to use that multitasking skill, but maybe in a more fun virtual environment. So VR allows us to get at that. And in addition, having a VR environment where you're getting at a multitasking skill, and say you're in a fantastical environment where you have some animated animals and you're trying to judge whether they are broken or not, and at the same time you're hearing a voice over the loudspeaker which is distracting you, that's going to really make you feel like you're not doing multitasking in your real life. It's going to be fun, it's going to be motivating, and when things are fun and motivating, people try harder. So from a testing standpoint, we can evaluate maximal functioning a little bit better. And in a treatment scenario, we can actually get people to work harder, increasing the compliance, increasing the adherence, also hopefully increasing the efficacy that those treatments have on the patients. Some of the core principles we have used in our studies in the applications that we've used to date are really involvement of the key stakeholders from the very beginning. So by key stakeholders for my domain, that would include clinicians because they're going to be using the software, and it would include the patients who will be undergoing the evaluation or the treatment. And when the software is developed, we involve them from the very beginning. We get their opinion. We have a prototype of the software. They go through it. They give us feedback. We revise the software. We give it back to the patients. They go through it. And we do this over and over and over and over again until we have a final product. And we can be assured from that approach, this iterative, very flexible cycle, that the finished product is going to really achieve the best that it can once it reaches the commercial market. So I wanted to highlight a couple of these. The finished product is going to really achieve the best. I wanted to, I'm hearing a bit of an echo. I wanted to highlight a couple of these different studies that I'm conducting. So the first one is funded by the National Institute on Disability Independent Living Rehabilitation Research, and the software we're calling it right now is called Wonky Wonderkin. Wonderkin Wonderworks. Wonky Wonderkin is actually one of the treatment modules. And this is an attention treatment, and it targets what we call task switching, so that's engaging in a task, someone interrupts you from that task, and you have to switch to something else, and then you have to go back to the original task, and then multitasking or divided attention where you're literally doing two things at the same time. Some of those things can include you're calling your health insurance company and speaking to them about a charge, and you're cooking dinner. Those things are multitasking, are things all of us do all the time, and particularly after brain injury, they're very, very challenging for individuals, and that has critical impact on patient populations because those sorts of multitasking skills and task switching skills are really what can impede someone from getting back into the community, getting back into gainful employment. So Wonderkin Wonderworks uses a traditional computer interface, so a mouse, a touch screen, or a tablet. And we have 8 modules in the treatment. We actually just completed development this week. It's been 3 years in the making. And what these screenshots really highlight is you can see where there's some tasks there, like real life. You have a kitchen here, so you're going to be toasting bread and making coffee at the same time. You have a desk scenario. You have a printer, a photocopier, and those tasks are nice because they mimic things you might experience in real life, but then we also have some different tasks which are more game-like, where you're dealing with some animated animals and they're jumping up and down and they're kind of distracting you and they're fun. There's a couple of these tasks that they seem rather silly, but they are very, very hard. And so these tasks range in level of difficulties for people who have very impaired cognitive function, and they can play these. They cannot be frustrated. They can be challenged at a level that's appropriate to them, and then they can also be very, very challenging, so people that are high functioning can use them, and they can still be very, very challenged and try and rehabilitate an area of weakness for them. So based on a little bit of technical difficulty with the presentation, I'm actually going to show my videos afterwards. Actually, is this one? This is one. Okay, this video is not working, so I will try and play them for you afterwards. So I'll just set the scene for you for these. This particular task is at a printer, and the person has to watch for printouts coming out of the left side. They have to be sorted according to what printout comes out up to these various cubbies up top. And out the right side comes some faxes. Now, why this is can get very complicated, we have full control over the speed of this, so it can be as simple or as complicated. But if you're ramping up the level of difficulty, if too many printouts come out of the left side, they can actually fall into the shredder machine here. And this guy is kind of hanging around looking for his fax to show up, and you actually are waiting for confidential faxes to come out. So you have to be quick about grabbing the faxes and seeing them before he does. And if they're not for you, then you can give them to him. But there's kind of a time pressure, so it really requires you to be focusing on both at the same time. And to add a level of complication, which is what is great about VR environment, is you can add distractions. So when the fax comes out, do you guys remember that really, really terrible old fax sound? It's incessant. So if you are doing really well, all of a sudden the adaptive difficulty kicks in, the fax machine sound starts getting worse. The character over here on the right, his name is Raymond, he starts chatting up to you and distracting you, and it gets very difficult very fast. The next video, which is also not working, is of a person at a desk. And the goal of this particular task is that an email comes in to your primary computer. You are to determine whether you are going to delete it, it's not a target item, or whether you need it. If it's an order, you send the order from here to your tablet. And the tablet then shows a portfolio of these animated animals, the Wonderkin, and you're supposed to go through and select which Wonderkin you need from the portfolio. At the same time, the character we saw in the last frame, Raymond, is coming by constantly with a box, a very, very heavy box. And you must drop everything you're doing and switch from what you're doing, tend to him, and then go back to the primary task. So these are just two examples of how we can create these complex environments. They are gamified a little bit, but they're very much mimic real life skills that we all use. Now I want to segue very briefly into the balance treatment. So Island Quest is a balance treatment, and we use a Connect-based system for this. This is also non-immersive. An infrared picks up the individual in the room and projects their avatar onto the screen. And using this technology, what we have created is a manualized treatment that targets 7 different domains. And within those domains, there are a number of different tasks, again, increasing in level of difficulty from easier to more difficult, so people with varied levels of impairment can use this software. And they occur on various parts of an island. So we see over here, the person is standing up and down in a box. We see someone over here walking and physically stepping over obstacles. And there's one task in particular, I'm hoping the video works, it's called fruit toss. And the whole goal of each of these different areas that are being targeted is to challenge someone's balance system. And some of them, in particular fruit toss, is the idea to get them off their center of balance, so they're challenging their balance system. Okay. So right here, here's a patient who has sustained a brain injury and he has impairment in balance. And this is a sit to stand task used in PT. And he is reaching down to pick up a fruit, and then he has to reach back up to pick a fruit. And on the surface, this doesn't seem so much different than PT tasks, or OT tasks. But if anyone has been to an OT or a PT gym, and I'm not knocking it all because I've been through rehab for an ankle injury myself, it's necessary work, but it gets a little tiring over and over again. And if you are seeing that you're picking up a fruit and you're leaning down to pick up a fruit, it somehow takes you out of the reality of the repetitive nature of it. And here's another video of the same patient who's playing fruit toss, and he's having to decide whether these fruits coming at him, he should either catch them or he should kick them. And I have played this before, and this is really, really hard. So it can, we work with military population, and the feedback we got during development was that the military are pretty much like working with professional athletes. They're very highly trained, and so a level of balance impairment for them was going to be much milder, so we needed to make sure that the software we designed was appropriate for a wide range of impairments. So last, I want to leave with a few thoughts on challenges and future directions. When I first got into using VR for rehab 6 to 7 years ago, there were a few things that came up for me, and the first was tech transfer. As a neuropsychologist coming from a rehab background in a nonprofit research organization, the amount of, nobody hands you a manual and says, here's all about tech transfer. So learning about intellectual property was one of the first obstacles that we came across. And understanding what was involved to get a product from start to finish. And when you are in a research environment, your incentives are to write grants and publish. And there is less of a motivation to develop a product and bring it to commercialization. So if you are able to be successful in doing that, you really require a culture in your organization that supports that. And that was a big learning point for me. Once you decide that this is the route you want to go, you have a supportive organization, you need to then have financial support, because it's not inexpensive taking a product from an idea and developing it and working a lot of hours with patients, and development is very, very labor intensive. So seeking the funding, knowing to go to the right places for the funding to develop the work to a degree where it's going to really be usable and of interest to clinicians once it gets out there. Once you get through that tech transfer piece, then the bigger part is, as mentioned in the earlier talk, is that if we're going to deploy this to clinical application, the payers want to see that it's efficacious. So you have to get a great product, you're still not finished, you have to validate efficacy through a randomized clinical trial or something similar to demonstrate that. And then finally, once you have all that in place, the clinician buy-in is really a challenge too, because people are hesitant to use technology. But I'll tell you this, the people that we have used to help provide feedback along the way, in terms of the clinicians, if you get the clinicians to participate in the development process, you actually have an in, you have a buy-in, because all of a sudden they become believers, They see how it works with their patients, they see how motivated they are, and then they're really motivated to use it in their own practices once it becomes available. So for future directions, we're really looking to do that validation of the efficacy in both our WonderCon WonderWorks trial and our Island Quest work. And we're also moving on to a couple other exciting areas with this one should play. So we are actually taking the balance treatment, and you saw the fruit toss, and we are starting to deploy this with the HTC Vive. And we found that the realism is, a world better, and the intuitiveness of where to reach for the fruit as it's coming at you is much more natural than using the Connect, not surprisingly. So for the specific tasks within Island Quest that are appropriate and safe for patients with balance impairments to use, we will be deploying the HTC Vive with it, and then starting to look at the efficacy of that. And then lastly, the new areas that we're getting into are we're going to start using a head-mounted display also to look at virtual reality as a spatial retraining system for individuals with neglect. And we're going to be using some of the 360-degree technology on the head-mount displays to look at training social cognition in individuals with social cognition impairments in MS and TBI. And lastly, I'd like to thank all the people who were involved in putting this research together. Thanks for your time.
Excellent presentation. Great. So now we are going to move on to our last presentation. Dr. Chowdhury is going to come. Are you all set here?
Yes, I'll be going next.
Okay.
Yeah, thank you.
Okay.
Wow, that was an incredible presentation, Denise. And I'm actually an alumni from Rutgers,
Oh, nice.
New Jersey Medical School, so proud to see the great work that they're doing there. So I think most of almost everything that we've spoken about so far tonight is focused on virtual reality. And this goes back to kind of that, the definitions I was speaking of, how virtual reality is all about immersion. So a lot of the therapies associated with pain, with PTSD and other, and marketing, for example, as well, you want the user's attention to be focused on what you're presenting to them and be distracted from their physical environment. Our team's work here with Mediviz has been focused more on the realm of mixed reality. So as you'll see, we're not trying to take the user's attention completely away from their physical environment. Actually, we think that physical environment being there helps in clarifying their understanding of what they're looking at. And you'll see what I mean when I get to that. And Mediviz was a company formed out of NYU. As I mentioned before, I worked there as a neurosurgery resident, and me and Chris, who's a radiology colleague of mine, we formed a company really with the goal to advance medical visualization using mixed reality. And we like to use this slide, and the first statement there isn't completely true. Medicine does an incredible job with what it has currently, the technology it possesses. And when we say that we have a visualization problem, what we mean is that for decades and decades now, physicians and surgeons, the way they understand their patients is always in 2 dimensions. Every CAT scan, every MRI, every ultrasound image that we get to understand what the patient may have wrong with them anatomically and what we need to do to help them surgically is always going to be a 2-dimensional cross-sectional image. And the problem is that the patient has always been 3-dimensional. Their pathology has always been 3-dimensional. So now with this incredible technology coming out in terms of visualization, how can we use that to improve our own understanding as surgeons and as physicians of our patient's pathology and perhaps help them in far more intuitive ways than possible before. And so what we believe is that mixed reality is actually the future of visualization. And if you see here, starting back in the late 19th century, we started off with just single film x-rays, and we moved to CAT scans, which could take slices at multiple levels. We moved to better soft tissue imaging in the form of MRIs, which are just a CAT scan, MRI are now essential in healthcare globally. And then you start seeing some work in the 1990s in volume rendering, and that means you're taking all these imaging modalities and creating three-dimensional images out of them. But the problem is you're creating these 3D images still on like a desktop monitor. So it's still a screen, right? And then more recently, there have been some companies that have done work in virtual reality. Virtual reality is incredible, as you've seen from what the panelists here have described. But the problem with virtual reality on a practical use from a day-to-day perspective for a physician is that there's a significant amount of VR-induced nausea. For patients themselves when they wear it and they want to understand something in the office. That's something they've had to deal with it significantly before, even for us as clinicians, when they try a VR headset on to look at a patient's medical imaging, they experience some level of discomfort. And then the problem when it comes to, again, with patients, understanding their medical imaging in 3 dimensions is, do you want to place a patient in an environment where they're completely immersed in their pathology? And some would argue that's unethical. Does a patient want to be immersed into an environment showing them their brain tumor or their spinal fracture or whatnot? And we feel that no, that's not what they would want. They would want their understanding to be augmented. But if another modality can deliver that level of information in the same manner without that immersion, that will eventually win out. And so that's where mixed reality comes in. And mixed reality is the ability to take all of this virtual information and overlay it into your physical environment so that you still see everything around you, but now it's as if you see this virtual information right there as if it's an object. And so you can walk around it, you can interact with it, and you're really tricked into thinking that it's actually there. And so this is kind of our earlier work. This is a video. And this was starting just a year ago, understanding how can we take pure modeling of the human anatomy and understand it in real world space. And so, a lot of the segmentation of the human body we did on our own. It took a lot of work, on our engineers' part as well. And we were able to understand new ways to interact with this sort of virtual information. So you saw before the gentleman was using gesture controls to kind of move around that holographic information. And even virtually, from a visual perspective, if something is remaining there, you kind of, if you want to see the back of it, you naturally walk around to the back and look at it. And you can do that in virtual reality as well, but having your physical surrounding around you makes it so much more comfortable because all those physical cues are still present. Let's go on to the next one. And so, our vision as a company, as we gain familiarity with this technology and we saw its potential in medical visualization, we want to see how can you introduce this into the medical world in a useful and effective manner. And we hope that eventually this will tackle so much more than what's being described on the slide. But as an initial strategy, we want to first focus on education. So education alone, the way it's been taught, I'll go into, and how we're thinking of reteaching that. And then from the clinical perspective, from the surgical perspective, how can physicians use the imaging they've always used, CAT scans and MRIs, in a new and much more visually intuitive manner. And so when it comes to anatomy education, this is a video. This gentleman, Frank Netter, is probably the king of medical anatomy. He's not probably, he is. Almost every physician in the world knows him and his drawings. And he actually was a professor at NYU School of Medicine. And his atlas of medical anatomy has been really the gold standard for learning anatomy both in medical school and nursing schools and PT, OT schools as well. Next slide. And the way we learn hasn't changed. Now, sorry for this photo for some people who aren't a fan of cadaver images, but but here, this is the traditional way most medical students learn gross anatomy now. They are participating in cadaver labs. There's an instructor there showing them a cadaver and going through it, and you see the student there on the right standing with Netter's atlas, trying to understand what she's seeing there before her with the two-dimensional images on the page. And medical students spend years just trying to put the 2 and 2 together. So is there a better way? And so that's where our work kind of came in on the Anatomy X platform. So here the whole goal was to model the entire human anatomy in three-dimensional space holographically. And so this is, it's present before you. You can understand it from any domain. You can call upon different organ systems, take them away. You can, mix and match different structures. You can label them. And you can understand much more from a virtual perspective than you could from a cadaver that can't give you that digital information, for example. And the great thing about this technology is that it's not just one person experiencing it. We're working here, this is specifically with Microsoft and their HoloLens technology, and they're a partner of ours. But if multiple people are wearing the HoloLens, for example, they can see the same holographic visualization in the same space, physically. And so that kind of Socratic method of teaching that we're used to in medical school is still preserved. We're not replacing that. The role of the physician educator is still there, but it can be enhanced with this virtual information. And so, that was a kind of a brief demonstration of just how we wanted to reshape anatomy education. And now, the other aspect that we wanted to tackle, me being a resident and operating on a daily basis, was how can we use this to rethink how we approach surgical imaging. And so, I love to show this image because it kind of demonstrates a problem that medicine has been stuck in. And on the left there, that is the first CAT scan image ever taken. It was by Dr. Hounsfeld in England, 1971. It was a young lady. She was in her 40s. She had a right frontal brain tumor. And if you look, it's been almost half a century now. And while the resolution of the CAT scan has improved, we're still dealing with grayscale imaging that's presented in cross-sectional formats. And so that paradigm has not changed. The other thing that's interesting is, I don't know if you guys know it or not, but actually in the image on the left and the right, the left side, notice I said right frontal tumor. This part here, you guys are saying, well, this is for left side. Well, since the CAT scan first came out, we've always considered left to be right and right to be left. And for many folks, that doesn't even make sense, but that's been the standard for decades now. And if you look in every operating room in this country and globally, you'll always see that two-dimensional image somewhere on the wall. Here you can catch it in the upper right-hand corner. And as physicians prepare and surgeons prepare for a case, that's what they're reviewing for the patient. And so we wanted to see if there was a better way to now take all this CAT scan MRI imaging, literally stack it and reconstruct it in three-dimensional space so that now you're understanding the patient as if they're actually there before you. We could help the patient understand their own pathology better. It could help the surgeon prepare for their case better so that they don't have to do these mental tricks in their, using kind of their mind's eye to understand this cross-sectional imaging in 3D space. And so we call this the RenderX project. And so this is a CAT scan of a patient rendered holographically. And so you'll see as the user walks through it, it cuts right through it. And that is all the CAT scan information now collected and rendered in holographic space. And this took a lot of work from our perspective. This is, again, just demonstrating kind of the gesture controls. This is a CTA, which is a specific scan that shows you the blood vessels present within the brain. And so I didn't want to take up too much time. Obviously, I'm the last person to speak, and all you guys are tired. But this is just the beginning of, I think, what will be an incredible journey in using this sort of technology to improve medical visualization overall. And while we're working with Microsoft right now, there's plenty of other companies doing work in this space as well. Magically, Google, Apple, and all of them are going to be coming out with visualization technology, which will just get better and better. And honestly, I see in 5 to 10 years a future where this stuff is going to become essential in hospitals, not just in the US, but throughout the world, because the amount of information it gives you visual-spatially is so powerful that it can really help patients when it comes to us being safer as physicians and helping them understand their own pathology as well. Thank you.
Thank you so much to all our panelists. I really think this has been just an amazing demonstration of such diverse application of this technology with such amazing, powerful results. So we are definitely running a little bit late, but I still want to have everybody have a chance to ask some questions. So while you're formulating your questions, I'll just kick it off with one. So we've talked a lot about data visualization in the course of all of this. Can any of you comment on whether the data that will be generated by the use of AR and VR technologies will itself be used?
Sure. I can talk. We do a bit of that. So this is software at the end of the day. So with regards to a lot of the programs that we deploy, we're able to understand the content that's engaged. If there's a free-form experience where we enable the customer to navigate, we can heat map it, if you will. So we'll see the content they engaged, the content they omitted. We are integrating in surveys, Q&A, et cetera. So all the traditional data capture are certainly applicable in VR. It's real time, again, as it always would be, because it is software.
And Dr.
I think the information you gather from a VR system is light years ahead of the information you gather from typical clinical practice, for precisely that same reason, is that every interaction can be captured, and that capture is immensely useful. So I myself have done a project looking at data used from a different VR exposure therapy technique that basically demonstrated the mechanism of action on the behavioral level that we expect is present during exposure therapy, but hadn't been demonstrated in PTSD exposure previously. And that's simply because the VR system records every interaction that therapists make, and I won't bore you with the details, but it wouldn't be possible without that data capture.
Great. So anyone else have any comments?
I would just say I would agree with the amount of data that's coming out of these pieces of software are immense, and probably more data than we can ever analyze in a lifetime. So any statisticians in the room that want to collaborate, we're always looking for people to help analyze the data. But that, one of the things we use our user testing suite for is to not just evaluate and record what the patient is, how they're engaging with the touch screen, for example, and they're engaging with touching a stimulus in the environment, but we can also evaluate, we can also video the interaction, so we can think about when they're going to think about making a movement, and from there we can help really fine tune, it helps us to understand what type of process they're going through. Even if the keystroke isn't recorded, we can still evaluate other qualitative data and other data from the user testing suite that helps us understand what types of challenges and areas maybe where they're having difficulty, where a keystroke isn't logged, but they're maybe hovering in front of the screen. So there's a lot of possibilities with the data that come out of the software.
Thank you. So why don't we go to the audience for a question?
We have a question back here, Ken.
Hi, my name is Lucas Merrill. I'm a consultant. I was wondering, so in the context of VR, obviously there are very, very exciting applications in the context of healthcare, but it's also a space that's been explored for more leisure video games. And I was wondering, particularly in the context of exposure therapy and for the Iraq-Afghanistan project, kind of the interactions between these VR technologies that are being developed and Call of Duty, and particularly in the context of that social aspect and taking it home, kind of. I was hoping you guys could speak a little bit about kind of those interplays.
Thanks, Lou.
It's a great question, and I'm going to assume it's directed at me. So one of the things that we can say right now is that we think this technology will be especially useful for today's generation and going forward, because they're so used to interacting with video games and 3D virtual environments to begin with. There's a lot going on in exposure therapy that is very different from the mindset and the typical role-playing that happens in a first-person shooter game. And I was speaking with somebody during the break And one of the things I feel very strongly is that once you're in an immersive virtual environment, the mindset of wanting to shoot someone is not something that even trained killers would likely express. It actually really shifts your point of view entirely, and the mindset of playing many of the video games that are most popular is highly violent and highly unlike the way that most of these people interact on a day-to-day basis and would imagine themselves. So once those types of virtual games become popular, where there is heightened violence, I think it will be very interesting sociologically and for numerous reasons how people respond. But I just want to say very clearly that the patients that we treat with exposure therapy, even though they have been in violent situations that seem highly similar, do not experience those virtual environments at all in the same way that gamers do. It's night and day completely different. And I think that the merging of those things, if it does happen, will be stark and dramatic for society. I don't know if anybody else wants to say that.
Thank you. So I think we had another question.
Yep. I had the mic, that must be me. I'm curious where you've applied this technology, in very real ways, but it still feels early stage to all of us. I think you'd all agree with that. Where are we in the hype cycle with AR and VR right now? Are we still waiting for pornography to make the big breakthrough, and we'll all have a lot of money now once they figure all this stuff out? Where are we?
I think hype cycle-wise, there's always that traditional graph where you have the early adopters and there's a dip after their enthusiasm runs out until people, and that's where people understand if technology is actually going to take off, it will take off at that point, the real practical adopters. And I think while VR and AR are very similar, VR has a step ahead of AR at this point, and that's because there's obviously more companies focused on VR. And so VR, most people will probably say, and some may disagree with me, but it went through its hype cycle maybe a year ago, a year and a half ago, and now the investment in VR is kind of shrinking a little bit. And the hype cycle, I think, traditionally also follows in investment as well. That's one way to understand it. And so now that it's shrinking, now those companies that were initially all VR oriented, we're going to see what they come out with, and whether it stands the consumer tests and the enterprise tests that are out there in the industry. So it's very much early. The other problem is time. These cycles are just time-wise, they're shrinking as we move forward in the decades. And so it took so long for smartphones to catch on, years and years. And for a VR headset and for AR, it's going to be maybe a quarter of the time. And it's just going to get faster and faster as more of society accepts that tech is going to be a part of their lives, and they're willing to use it in powerful ways.
Thank you. We have another question.
Yeah, so I wanted to ask, I would say if, but I think it'd be when. When the rest of the senses, the sense of smell, taste, and touch are incorporated into VR, AR, MR, how do you think that will impact your field of study?
Just really briefly. If you're going to incorporate smell, do it in a room with a very big fan. Those scents linger. The scent machines are powerful things. Just a practical tip.
Yeah, I mean, personally, I don't see that being of much value. It was something that they established early on, and it fell by the wayside in favor of the visual aspect. Visual and audio is really where the stimulation is coming from.
That being said, I think haptics is a very interesting territory, and who knows what happens in the coming years. If haptics develops, it's obviously the hardest sense to replicate in a realistic manner, but there's so much out there in terms of science fiction. I don't know if you folks have read books like Ready Player One or others where you're just completely, people give up their physical lives in favor of virtual lives, and that's where they find fulfillment. And that's why Facebook acquired Oculus, because they think that's the sort of future. People will be meeting virtually and living their lives virtually. So who knows? I mean, it can be an incredible future, and it can also be scary and anxiety-inducing as well. It goes down that track.
I have one more quick comment.
Very briefly, I could see application of the sense of smell applied in an evaluation tool. There's some patient populations, such as Parkinson's, that have smell impairment, so you could use it that way. I don't know how widespread it would be adopted, but there would be an application for it.
Thank you.
This is a question for Dr. Kirsch, but I think anyone could jump in. Doctor, when you presented your application, it was in terms of occupational therapy and physical therapy for someone who had experienced a traumatic event, some brain event or something similar to that. And I wonder if you've also mentioned some of the forward-thinking applications beyond just those. Any thought given to individuals who are experiencing cognitive decline, as we think of Alzheimer's and other degenerative brain conditions, not specific traumatic event, but gradual decline as a way of maintaining stimulation and maintaining brain function. Any thoughts given to application of your technology in that regard?
Yeah, I think, well, perhaps I'll just talk louder. These sorts of treatments, these cognitive rehab treatments, can be applied to other rehabilitation populations. I mean, multiple sclerosis is one example that would be considered a disease process that declines over time. They're not an older population such as Alzheimer's or a dementia population, but there's certainly a lot of application of cognitive rehabilitation treatments for patient populations like MS. As far as the field goes with dementia research, there's a lot of research out there on mild cognitive impairment and identifying people early on in the dementia process, and I think there's certainly an application for using a cognitive rehabilitation treatment if you identify individuals early in the cognitive decline process that can help maybe extend the number of years they remain at work or extend the number of years they have before they require assistance with carrying out activities of daily living or instrumental activities of daily living. So I absolutely think that will be an area to go into.
Thank you.
Alex, I can just talk loud.
No, actually, because the internet is listening, so.
Oh, sorry.
But I would like to say something about Matt. So Matt was the first dues-paying member here at Health 2.0 New York. Thank you, Matt.
No worries.
Okay, so go ahead.
Thank you for that introduction, Alex. Just as a follow-up to what you just said, there's been a lot of talk about dementia, and I'm glad he brought that up, about actually using VR to bring up, and I guess they call it exercising old muscle, memory muscle, right? So actually showing flashbacks of your childhood, all these kind of things. I just wonder if any of you have done any studies about this, if it is real, and do you have any thoughts, because I have a parent that's going through this now. I am very vested, and I'm sure many of us in this room have people that are, having these kind of conditions. What do you think of this research? Is it going anywhere? It seems to be the future, and what companies are investing in this? What are the hot companies in this space? So just as a follow-up to that question, thank you.
I'm not sure about the investing answer to that question. It's a tough area because I also watched a grandmother slowly decline from Alzheimer's, and the tough part is once they reach a threshold, I could get into a cognitive reserve talk right now. Once you deplete the resources, there's very limited benefit to rehabilitating at that stage. There are certainly a lot of wonderful, amazing things you can do to help jog that person's memory from their own personal life to kind of keep them who they are as long as possible. But I'm not aware of any work in VR that is extended into looking how to apply that to, my first thought would be it would need to be very personalized in order for it to be meaningful. Because if you have watched someone who's declined with Alzheimer's or another dementing illness, you know that they can perk up from certain stimuli. And so everything else in the environment really may be not relevant to them, but it might be the sound of a grandchild or something personally relevant that kind of bring them out. So I think it would be really cool maybe to tailor the technology so you could, and I believe some companies are doing that, maybe you guys can speak to this. Some companies are creating kind of like a shell of VR software that can then be kind of tailored. So you buy it, it's got some basically programming elements, so it's very user friendly. It's got a good user interface, so someone who's not tech savvy could get it, and perhaps that sort of application could be used by a family member who wants to help that individual but can't be there all the time, or they're long distance. I think that's a great avenue, but I'm unaware of any work in that area yet.
As a patient advocate and as a person whose grandmother had Alzheimer's in the 1970s, this is something that's really interesting to me. And I worked a year or so ago at a place called Mass Senior Care and learned about a couple of amazing things that don't quite tip into your idea, but perhaps that'll be impetus for you to consider startup. One is, and I just Googled it, it was Gizmodo, an article from 2014. There are these villages, I don't know if you've heard about them, they're designed for people with dementia, and they set like, they look like the 1950s, it looks like a movie set. From the gas station to the music, so forth, everything just designed to get those neural pathways that have these deep, deep grooves where there's 30 years missing in between then and today, to reactivate that. And to not have a classic nursing home physical setup either, to have little care platforms. And I think even Atul Gawande wrote a little bit about that in Being Mortal, that came out a couple years ago. But the other thing I'm sure you've heard and seen on the internet, which is fascinating, and which we get to see with my almost 98-year-old mother-in-law on a weekly basis, is when my husband puts Sirius XM radio on for the 1940s, she cannot remember the name of her granddaughter's dog. I have to write on the piece of paper, it's Gus, because she will ask us 10 times over the course of a meal, what's the dog's name, what's the dog's name? But she knows every word to every song from the 1940s. I joke and I say to our son, okay, hits from, rock and roll from the 70s and 80s, and I'll respond to you. It can unlock this pathway, so you might be onto something.
Any more questions?
You guys have a lot compared to VR technology to mobile phones and looking at the numbers, but you also mentioned the word toaster. And I'm wondering that, the adoption rate of cell phones cannot be applied to that, because a cell phone can be taken anywhere, whereas someone cannot necessarily wear something around their face all the time. How do you keep innovating enough until you eliminate the device so that it can be used anywhere, as opposed to getting stuck being a toaster? Because yes, toasters are in every home, but no one is having a discussion tonight in a big room like this talking about the future of the toaster.
You don't know that.
You have something against toasters.
My wife's allergic to wheat, so yes.
No, I mean, the point you just raised is something almost every major tech company in the entire world is trying to solve, which is how do you bring this technology in a form factor that people can use it practically on a daily basis. And so I think the answer you're going to find maybe over the next decade or so as the technology miniaturizes. So the first thing is actually having the cell phone in your pocket is a boon to the VR AR movement. That's why Google is working on their technology with Tango. That's why the Gear VR works. It's just an incredibly powerful computer in your pocket. And so now if you want a VR or an AR experience in the middle of some random avenue, you could imagine a future where all you have is glasses probably the size of what you're wearing right now, that can just literally communicate wirelessly through a connection with that powerful computer, and all that processing is done on that computer within someone's pocket, and just the visual information is ported, the audio-visual information is ported directly to someone's glasses. Would they use it every day or all the time? Are we going to be living in a world where everyone is wearing these sort of glasses in 10 years? And no one knows. But if they add a sense of a practical use, the way the cell phone brought to people, you're going to see people adopt. Like 10 years ago, no one could think that now you enter a New York City subway, everyone is staring down at their cell phone. And sometimes I look around, I'm like, what's become of this world? But it's because people find meaning in that use of that device. And so you could see something similar happening with AR and VR as well, if the technology becomes more comfortable.
Yeah, I think from my view, the excitement comes from the content and the style by which it's being built. So in a lot of meetings that we partake in with some of the big tech companies, the notion of 360 first is really a topic for discussion. So thinking about it as content creators, that's really what I believe the immersive multimedia movement is all about, is conditioning other content creators across digital or film to orient what it is that they're crafting from a storyline and storyboard perspective to be delivered as 360. So produce it that way first. As a marketer, I do believe that the goggle is the optimal solution for delivering it in a way that's most meaningful and relevant. But if you build it 360 first, now also then with the advent of the 360 video players like YouTube and Vimeo, etc., that same content, so long as it's been built as 360 first, it can be used across devices. So you're not limited even now to just the goggle. Again, I would argue it's better in the goggle, but if I wanted to open it up on my phone, which is the great equalizer, it becomes the magic window into that world. Or I can use my finger to look around it. So that's what I see, that's what we're a part of, is advocating for that. Whether it's going to live on a movie screen, a TV screen, a cell phone screen, or in a goggle, so long as it's being built to enable 360 and enable that really immersive media storytelling, that's the movement at the moment. That's where the future's going. So you're not limited to the device.
Do we have another question?
Hey all, Will Treichler. So one of the things I've noticed, being a casual observer of technology over the years, is the law of unintended consequences. So you take, we've talked a lot about cell phones, and while they've been amazing for a lot of reasons, we talked about one unintended consequence is everybody's doing this all the time. There were also a lot more malignant unintended consequences. Are there any elements of that in your lines of study or fields of expertise that you could say or make arguments for that this is ultimately going to harm people? Or in other words, are there things that you're scared of in the applications of the technologies that you're working in?
I'll just take that to start. I think, again, it goes back to the content. Because VR and even AR, they in combination have the ability to transport you from your physical world into this virtual setting. And when it's done well, it's so good that it tricks the mind and the body into presuming it's elsewhere. So yes, of course, if the content is inappropriate or whatever the case may be, it can become scary. You can create negative experiences. I don't think anything that we're necessarily touching or is really being built in that capacity, but certainly with something that's so visceral as VR that can actually trick you into presuming you're not in the burn victim unit, but instead throwing snowballs at a snowman, you can imagine the potential it has. So I guess that is all to be determined.
Yeah, it's an excellent question, and the technology itself is never the root of any like you said, malignant after effects. It's always how we as a civilization decide to use the technology. And the cell phone was initially used for business cases, and it was used to read your email, and eventually you're using it to swipe right and left on Tinder. So it's like that's what people get addicted to. It's how that technology evolves. And people have there's a great video on YouTube, I forgot the name, which showed a theoretical future with mixed reality, and it's literally this lady with these goggles on, and everything around her is hyper stimulating her, and it's just there's advertisements everywhere, and she can it's all life is all about collecting points or whatnot, and that sort of future can be possible. We live in in our country, it's a capitalist environment, and it's driven by marketing and advertising. And while the panelists up here are trying to focus on use cases in the healthcare world where we think we can help people, the technology can be leveraged for more nefarious uses as well, and especially stuff that can keep people addicted and watching the screen. So definitely something we have to be careful about, I think, over the coming years.
Any other questions? No question. Why don't you just speak loudly until we get
Sounds good. My question actually is for the exposure therapy. I wasn't prepared for your talk, but you know, EMDR has been used to treat patients with PTSD. Hello? 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 Oh, there we go. I was asking about exposure therapy. So EMDR, which is eye movement desensitization and reprocessing, has been used to treat patients with PTSD or other traumatic events. So has there ever been any studies looking at how EMDR works and see if it could integrate it to VR? Because you can imagine that there's similar kind of sensory input, right? And whether there's been any more studies kind of discerning why EMDR works for patients with PTSD or, you know, trauma victims.
So without getting too far inside baseball, just for the sake of the rest of the audience, there have been studies showing that EMDR, which is another type of therapy, is effective and seems to be effective basically at a neural level on the same mechanisms that exposure therapy works on. And in fact, some people teasing those things apart in EMDR seems very difficult. So it seems like EMDR is one avenue to do exposure therapy essentially without doing all of the same things.
So have people looked at doing EMDR with VR, or like is that possible?
It should be possible. I mean, EMDR is also, for the audience, is one of the earlier technology-based psychological interventions. So there are pieces of technology that help you do these kinds of works. And it should be possible that you could be in a virtual environment where the types of movements that are done as EMDRs are feasible. That would make sense to me.
Any other questions? I think we're good. Okay, great. Well, thank you all for this amazing presentation. Thanks everyone for coming.